The following podcast is part of a certified educational activity titled Transforming Bladder Cancer Treatment, Essential Guidance for Urologists on Therapeutic Selection, Safety, and Sequencing Along the Disease Continuum. Access the entire activity and complete the post-test at peerview.com/RMY860. Downloadable slides and practice aids are also available.
Hello, I'm Ashish Kamath, Professor of Urologic Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas, and it's my pleasure to welcome you to this educational activity entitled Transforming Bladder Care Treatment, Essential Guidance on Therapeutic Selection, Safety, and Sequencing Along the Disease Continuum. Our goal today is to explore some of the recent advances in the treatment of bladder cancer from early to late stage disease, highlighting numerous options including chemotherapy, immunotherapy, bladder preservation, Fgfr inhibitors, and antibody drug conjugates. We'll cover what these advances have meant for patients as well as their multidisciplinary provider team. So first off, why is this important? Well, we all sort of recognize that BCG is the original cancer immunotherapy. And in fact, when there is no shortage of BCG, 1.2 million doses of BCG are used globally for bladder cancer every year. But despite this, BCG doesn't work in everybody. It has a very high initial response rates, but ultimately at about a year, 30% of patients will have recurrence of their tumor, and at about 2 to 3 years, roughly 40% of patients will have recurrence of their tumor. And even though this is improving in recent times and less recurrences are noted, it is still roughly in the range of about 30% of patients that will need another treatment after BCG immunotherapy. Multiple groups, including ours, have come together and tried to come up with predictors of response to intravesical BCG. This is just a recent panel publication that we put together that categorized the markers or the predictors into definitely useful, probably useful, and emerging strategies. As you can see there, we're excited about the emerging strategies, which are molecular subtypes. But the only real predictors that are definitely useful today, even in 2022, are the clinical pathological features: age, grade, stage, recurrent tumors, multiplicity, CIS, female gender, etc. We can use FISH patterns and we can use genomic signatures, but for the most part, these do not supplant classic predictors. And if you look at the landscape of the evolution of therapy for urethral cancer, most of the advances in therapy have occurred in the recent decade. You can see here for the longest time, we only had chemotherapeutic cytotoxic agents. Then in 2015, 16, thereabouts, there was a slew of IO agents that were approved. And of course, more recently, we have approval of EV and SG, and I'll talk about those. But that's been in the advanced and metastatic setting. When it comes to the non-muscle invasive setting, for the longest time, we only had two agents, BCG and valrubicin. And it's only recently in the year 2020 that Pembrolizumab was approved for the treatment of patients with non-muscle invasive bladder cancer. So why is this? Well, if you look at the classification of BCG failure, which is very important when we're designing clinical studies and when we're actually looking to see what the results of reported studies are, this was all over the place. We had patients who were classified to be BCG refractory. Then we had patients who were classified to be BCG relapsing. We had patients who were classified to be BCG intolerant, which actually was the easiest subgroup to classify per se. But because of these multiple definitions, regulatory bodies and investigators could not really make head or tails of what was actually being reported or read out. It was only recently that the AUA got together with several experts, including those at the FDA, and then two groups, the International Bladder Cancer Group and the ASCO group led by Dr. Lerner, and you can see the references here, provided advice to the FDA, which they then incorporated into their guidance document, which was finalized in the year 2018. Based on this guidance document, there was an explosion of clinical trials in this disease space. Now, it's important to recognize what this definition is. So let me spend a minute here. For a patient to be considered to be BCG unresponsive, and keep in mind, this is a definition more for entry into clinical trials and for us to understand the implications of the clinical trial. But for a patient to be considered to be BCG unresponsive, he or she either has to have persistent or new T1 high-grade disease at the first evaluation at 3 months following induction BCG. For everybody else, the patient has to have at least induction BCG and 1 maintenance course. And then if the patient has persistent or recurrent CIS, this time frame is within 12 months of the last exposure to BCG after having completed adequate BCG. If the patient was disease-free and then recurs with papillary disease, so that's TAI grade or T1 high grade, then that recurrence has to be within 6 months of completing adequate BCG. And this is the definition of BCG unresponsive disease that regulatory bodies, the FDA, have allowed investigators to use in single-arm studies, and I'll touch upon a few of them in later slides. So why is this time frame important? Why does it matter? Well, this is just one example of an exercise I performed on a paper from Don Lam in the year 2000. You could do this really with any exercise or any manuscript that has patients with CIS. So in this study, there were 278 patients with CIS, and they were randomized to either induction BCG alone or maintenance BCG, so induction and maintenance. If you look after induction BCG, in both arms, the CR rate was about 55-58%, which is what we commonly see in patients that have carcinoma in situ, where they essentially have a roughly 55% CR at 3 months. Now, if you do nothing, in the patients that had only induction BCG but just give them some time, the CR still goes up from 58% to 69% at that 6-month interval. But in the arm where you give them more BCG, so adequate BCG, the CR goes from 55% all the way up to 84%. Now, imagine previous trials that came in at the 3-month mark at that 55% CR rate, gave drug X to the patient, and then had about a 30, 40, or even 50% response rate. It was considered to be a victory. But in the real world, that did not pan out. Because if you just gave the patients adequate BCG, which is another maintenance course of BCG, 65% of these patients could be salvaged or actually would convert from a positive response, so not a CR, to a CR. And that's very important. And of course, this was an expert opinion that was given to the FDA and adopted, but several people, including this publication from Roger Lee, who used to be a fellow at MD Anderson but now is at Moffitt Cancer Center, looked at this definition and has shown here that in patients who are BCG unresponsive in the real world, that definition does allow us to stratify patients, and clearly those that are BCG unresponsive have worse outcomes when it comes to cystectomies, high-grade recurrences, and progression, and hence this definition clearly is valid. Now, after this definition came about, there was an explosion of clinical studies. This is a pictorial that Noah Hahn from Johns Hopkins put together for a discussion that we had relatively recently. And you can see here multiple clinical studies coming out, and I'll touch upon a few of those in the next few slides. So one of the most sentinel publications and approvals was that of Pembrolizumab. And this was, in fact, still the only drug that has been approved after the adoption of the new paradigm by the FDA. This was based on Keynote 57, which is represented here. This is where patients that had BCG unresponsive disease, so all the definitions that I talked about previously, were enrolled into a single-arm study, a registration study, where the patients received Pembrolizumab 200 milligrams every 3 weeks. This was the dose and the frequency at that time. Of course, now we know Pembrolizumab can be used in larger doses and less frequently, but this was what this trial was designed. And the patient underwent cystoscopies, cytologies, and biopsies at 3 months, so that's 12 weeks, and then every 3 months for 2 years, and then every 6 months thereafter until they came off the study. If you look at the inclusion criteria for patients in this clinical trial, you can see here classic inclusion criteria, classic baseline characteristics of patients that you would expect in such a study. The median prior BCG installations was 12, again, showing you that this was a fairly highly pretreated group of patients. Now, what I want to focus on is the reason for patients entering the study. Even though most guidelines suggest that patients should undergo radical cystectomy, and the trials are designed to say these are for patients who are not candidates for radical cystectomy or who refuse radical cystectomy, in the real world and in clinical studies, we find that most patients actually select or elect to go into the study because they refuse a radical cystectomy. They don't want this life-changing surgery that is currently the standard of care. The response rate with Keynote 57 is depicted here. This is a classic money slide. You can see here that the CR rate out of the 96 patients that were presented and evaluated at the FDA ODAC was 40.6%. What was fairly impressive and pleasantly surprised many of us was the duration of response, because this was greater than a year at 16.2 months. Now, with an extended minimum follow-up of 26.3 months, you can see that 33.3% of patients still remained in CR at greater than 18 months, and 23.1% remained in CR at greater than 24 months as of the data cutoff. So this is data that is actually fairly impressive, and we weren't expecting this, and this was very encouraging to find. Of course, systemic drugs do have toxicity, but none of the toxicities that were reported in this study were different from what you would expect from systemic pembrolizumab in the more advanced or metastatic patients. And of course, this is a place where the urologists and the medical oncologists do need to come together and collaborate, because in some settings, of course, the urologists might be able to give systemic drugs on their own. In some settings, urologists are not able to do this on their own. Either way, it's a partnership that needs to be emphasized. But anyway, based on this data, on January 8th, actually, of the year 2020, the FDA approved pembrolizumab for the treatment of patients with BCG-unresponsive, high-risk non-muscle invasive bladder cancer with CIS, with or without papillary tumors, who are not candidates for or who have refused to undergo a radical cystectomy. Now, of course, pembrolizumab is not the only IO agent that has been looked at in this disease space. This is SWOG 1605, which looked at as atezolizumab in the same cohort of patients, BCG-unresponsive non-muscle invasive bladder cancer. And even though the endpoints in this study were designed differently, they looked at CR at 6 months, which is 27%. If you look at the Kaplan-Meier estimates, the curves superimpose and overlap almost identically. Now, of course, this study was not designed in the way that Keynote 57 was, so whether or not atezo will be approved because they didn't meet their designated endpoint remains to be seen. Now, IO agents are also coming into earlier stages of disease. This is Keynote 676, which is pembrolizumab plus or minus BCG. You can see here patients are enrolled at an earlier stage. So these are patients who are not BCG unresponsive per se. They've received BCG and then have recurrent high-grade disease. And then they're enrolled into the study with BCG alone, which is, as I mentioned, standard of care, or BCG plus pembrolizumab. And then they're followed as per standard of care. Now, of course, in times of BCG shortage, there is another arm here where patients really can come in at a naive setting when they have had no BCG at all and get on the study, but this is the classic Keynote 676 as it was originally designed. So what is this BCG exposed thing that I'm talking about? Well, if you think about it, that BCG unresponsive definition was put forward and adopted by the FDA to denote patients that could enroll in single-arm studies for registration purposes. But clearly in the real world, patients don't get BCG in an optimal manner. And of course, we are facing a global shortage right now. So a lot of patients can't get BCG. All these other patients that have some exposure to BCG, so BCG exposed, fall into that broader category, which the International Bladder Cancer Group has proposed, and the FDA has taken it under consideration, for patients to enroll in the clinical studies. But these clinical studies will require a control arm. And anytime the viewer looks at a study that does not say the patient is BCG unresponsive, look for a control arm, because otherwise it's hard to know whether the patient would have been benefited from standard of care alone. Now, talking about BCG exposed and BCG naive patients, you can see here just a graphical representation of the numerous studies that are in this space. BCG exposed, I talked about Keynote 676, which is Pembrolizumab. We also have Checkmate 7G8, which looks at Nivo, Adapt Bladder trial, which is with Durva plus or minus radiation therapy. And of course, in the BCG naive study, Potomac is looking at BCG induction plus maintenance versus BCG induction and maintenance plus Durva versus BCG induction only plus Durva. And again, that is because we don't know when the shortage of BCG will be abrogated. And if you can cut down the requirement on BCG and add IO agents, that might allow patients to actually get on more treatments. Similar study is Alban with Atezo and Crest with the subcutaneous formulation Sasolizumab. So that's non-muscle invasive bladder cancer as it currently is state-of-the-art today. If we move into muscle invasive bladder cancer, we all recognize that neoadjuvant chemotherapy is the standard of care for patients. This is a study that was published by Bart Grossman, one of my former mentors and colleagues, and this is from the year 2003. This shows that MVAC clearly adds survival benefit over cystectomy alone, and based on this, this is the standard of care in all the guidelines and all the textbooks. But if you look at surveys and investigations, and this is just one example of a survey and summary at the SEO meeting several years ago, you can see that a minority of patients who should actually get cisplatin-based neoadjuvant chemotherapy actually get it. In the year 2010, only 20.8% of patients got neoadjuvant chemotherapy. This was updated recently, and I believe the numbers are up to 25%. So not much improvement. And we need agents that more people might feel comfortable using, because one of the so-called reluctances to provide chemotherapy to patients on the part of the surgeons who refer these patients to the medical oncologist is the perceived toxicity. Again, a plea to everybody that's listening to engage with your medical oncologist. And if you're on a medical oncology side, of course, engage with your urologic surgeon colleagues to encourage more patients to get this standard of care. But till then, we have to look at other agents and study them, and that has been done. So if you look at neoadjuvant studies that look at checkpoint inhibition alone, you have PURE-1 study, which is with Pembrolizumab. You have the Advocacy study with Atezolizumab. You have the Durva plus Tremi study, the Nivo plus Ipi study, and of course the Nivo plus Urolumab study. And in all of these, patients got the checkpoint inhibition single agent or combination prior to radical cystectomy. And the PAT-CR rate ranges anywhere from about 26 to 42%, which is fairly impressive. This is something that we are expecting to see and do see in patients that get standard of care cisplatin-based neoadjuvant therapy. And to see that with checkpoint inhibition alone was an exciting finding and really indicates a true signal for IO agents alone in this setting. Now, of course, people have looked and tried to enhance these response rates and also check and see if you can provide IO agents with chemotherapy. You can see here some examples. The BLAST-1 study is GemCis plus Nivo. The Cancer Research Network study looks at GemCis plus Pembro. Then we have another GemCis Pembro. And of course, Atezo GemCis is another study. Again, if you look at the PAT-CR rates, you can see that they range from 39 to 49%. So roughly in that 40% response rate, which is really, again, fairly encouraging and very similar to what you would see with more toxic agents alone, but in some ways better than what you would see in those older studies. Now, data from BLAST was updated relatively recently by Dr. Gupta at ASCO earlier this year, and she reported that at a median of 15.8 months follow-up, recurrence-free survival for these patients was 85%, and progression-free survival was 83%. And molecular subtyping was performed as part of her report, and the basal type of tumors, there was a suggestion, as has been suggested in previous publications with other agents as well, that they may respond more favorably because of the cisplatin chemotherapy in the combination. And of course, there are ongoing phase 3 trials with neoadjuvant immunotherapy in the cisplatin ineligible cohort of patients. You have again IO or IO plus a novel agent. Patient undergo radical cystectomy, and then depending on the entry criteria, either continue on the treatment arm or undergo observation. One example is that of Pembro plus EV, which is Keynote 905 or EV303 as it's known, Gemcarbo plus Nivolumab, Volga study. And of course, in the cisplatin eligible patients too, we do need to study this. And in this group of patients, of course, we can't ignore the standard of care, which is cisplatin-based chemotherapy. So that forms the control arm plus placebo. And of course, the treatment arm essentially is IO plus chemo or IO plus a novel agent. And then depending on the study, whether it's Energize, which uses Nivo plus IDO1 inhibitor, the Niagara study, which uses Durva, Keynote 866, which uses Pembrolizumab, or Keynote B15, which again is better known as EV304, is EV plus Pembrolizumab in this paradigm. Moving a little bit away from the neoadjuvant setting to the adjuvant setting, there are again studies and trials that look at PD-1, PD-L1 inhibitors. IMvigor10 is one that is most well known in some ways because of the first to report out. And here it did not meet its primary endpoint. This was patients that entered the study based on entry criteria, which I'll expand on in my discussions on Checkmate 274. And after undergoing definitive surgery, based on the entry criteria, they were either randomized to atezolizumab or observation. And the primary endpoint was disease-free survival. Unfortunately, this study did not meet the primary endpoint as was designated. Checkmate 274 was a very similar disease or a trial design. And here the patients were randomized to Nivo or placebo, which might have been one of the key factors that allowed these trials to actually read out as being positive. And this primary endpoint was disease-free survival with key secondary endpoints of overall survival and disease-specific survival. And based on the results, which I'll show in the next few slides, this was FDA approved just last year. Of course, Ambassador is the trial that uses Pembro and randomizes to observation. Many people are kind of using this trial as sort of a tiebreaker to see what the results are, to see whether they actually believe the data from 274 or not. But 274 actually did have a positive readout. So what was that positive readout? The bottom line is the inclusion criteria for these patients were either no chemo and advanced disease stage on pathology, or chemo and advanced disease stage at pathology, including node-positive disease. And when patients were randomized to either nivolumab or placebo, you can see here that there was a clear benefit both in the intent to treat population, which the median was 21 months compared to placebo at 10.9 months, or also in the high PD-L1, more than 1% was the cutoff here, patients where the median survival with Nivo has not been reached, and at placebo, of course, it's 10.8 months. Now, one thing to keep in mind is that this trial did have placebo as a control arm. There's some concern that IMvigor10 might not have been as robust because of the observation arm, where patients could clearly come off of it if they didn't know, if they knew that they were not getting the agent that they enrolled for. The other thing was, if you look at the actual median disease-free survival in the placebo arm here, it was lower than what was seen in the control arm in IMvigor10, which might be another reason that the two studies had different endpoints. But the bottom line is this study was read out as positive, and that's what led to the approval of the agent. Now, if you look at the safety profile, no surprises. This is the safety profile that you would expect from more advanced disease states. The most common grade 3 AEs were, as you would expect, the itis, the colitis, the diarrhea, the pneumonitis, and of course the alterations in lab values. So I just want to use this one case to highlight this type of patient. Young, relatively healthy patient for bladder cancer, a marathon triathlete in excellent health, has some hematuria, ignores it, thinking this is run as hematuria, unfortunately. And by the time she's diagnosed, she has advanced but still clinically localized muscle-invasive bladder cancer, has good renal function, so undergoes radical cystectomy in a neobladder. Unfortunately, pathology comes back T3b. 38 lymph nodes were removed. They were all negative. Now, based on the results of Checkmate 274, adjuvant nivolumab is a strong option for this patient, even if she hadn't received neoadjuvant chemotherapy. And it's important for the urologists in the audience to recognize that, because oftentimes these patients are seen by the urologist, they follow up with the urologist, and may never have the opportunity to discuss adjuvant therapies that are provided by our medical oncology colleagues. So it's important for us on the surgical side to recognize that this is a patient that should have a discussion of the pros and cons of adjuvant therapy, should have a discussion about the results of the studies, and ideally, unless you're in a country where you're giving your own systemic agents or in a location where you're doing that yourself, should be referred to medical oncology to have that discussion and then can make an informed decision. Now, sometimes patients are not candidates for radical cystectomy. So let's shift gears a little bit and look at some of the non-surgical options that are available to our patients. So bladder preservation. Now, bladder preservation has been around in some form or the other for many years. There have been attempts to perform phase 3 randomized studies, but clearly it's very hard to randomize a patient to radical cystectomy versus trimodal therapy, which is bladder preservation. There have been studies, especially overseas in the UK, that initiated this but had to close because of the futility. So it's encouraging to see a resurgence in the studying of trimodal therapy in the United States. And a lot of this excitement and resurgence is because of the use of IO agents, which is allowing more people to both get funding, do investigator-initiated studies, and this is one example. This is a phase 2 study schema that was presented by Alger and Bladder, but using pembrolizumab and gemcitabine with concurrent hypofractionated radiation therapy. The key inclusion criteria are obviously bladder cancer, mixed histology is allowed, the patients have T2 to T4A N0 disease, ECOG performance status of 0 to 1, and these patients should either be refusing radical cystectomy or not be candidates for radical cystectomy. No perioperative chemotherapy is allowed. These patients go on to get pembrolizumab, maximal TURBT, which appears to be really a critical factor in driving the response rate to the subsequent chemoradiation and treatment that these patients get. And of course, pembrolizumab is added on here because that's what's being studied. The assessment of response is done with a TUR of the tumor bed plus urine cytology, and imaging is being used and studied to see if we can ultimately use imaging to supplant the staging, because we all know that clinical staging of bladder cancer is fraught with a lot of difficulty and a lot of fallacies, but that's the best thing that we have nowadays. If you look at the results from the phase 2 study with pembro plus gem plus concurrent hyperfractionated radiation therapy, at a median follow-up of 14.6 months for the efficacy cohort, the primary endpoint of estimated 1-year disease-free survival rate was 88%. The CR was 77% at 12 weeks post-radiation therapies, and you can see that there in the Kaplan-Meier curve depicted in the red line. So again, very encouraging. The 1-year estimated bladder intact disease-free survival of 88%, very encouraging for our patients. And especially when you look at the immune-related toxicities, these were, again, not anything that you would not expect. These were fairly manageable. Steroids are required in some, most were manageable. Things that we, when I speak of the global community, is used to dealing in patients that have more advanced disease. Of course, there are ongoing randomized studies, including Keynote 992, the SWOG 1806 study, and the INSPIRE study, which will better define some of the role of immunotherapy when it comes to bladder preservation. But it's the insurgence of bladder preservation which is really exciting times for our patients, because this is an option that clearly deserves a lot of attention. And this is another example, phase 2 Immunopreserve, which was presented by our colleagues at ASCO last year. This is looking at durva and tremelimumab with concurrent radiation therapy. Patients get their TRBT, they're then given durvaltremi, and then get radiation therapy to the pelvis, the true pelvis or minor pelvis as it's called, with a boost to the bladder, and then go on to get TUR for response assessment and either bladder preservation if they have a CR, and if they don't have a CR, then of course they go on to get salvage cystectomy. This is the data from that study. You can see here that the CR post-treatment biopsy was seen in 81% of patients. Again, a high percentage of patients, and an estimated 12-month disease-free survival with bladder intact was 73%. Disease-free survival was 76%, overall survival of 87%. And you can see that survival probability curve on the right of your screen. Again, you do have some toxicity, but the grade 3 to 4 treatment-related adverse events were reported in a third of patients. Nothing that we would not expect, nothing that we would not be able to manage if these patients are appropriately seen in the relevant clinics. Now, there are neoadjuvant trials that are looking to see if we can use molecular markers to help predict and triage patients for bladder preservation. This is one study that was reported out by Matt Galsky looking at the Ddr mutations to see if you can help patients into the different categories. Now, for those that might not be aware, the Ddr mutations are essentially ERCC2, FANC, ATM, RB1, and TMB. A lot of people have sort of focused on tumor mutational burden as sort of the holy grail. It doesn't seem to really be the case per se, but that together with the others, ERCC2, which has been well studied, and of course, FANC, ATM, RB1, does sort of help us give incremental predictive and prognostic power to these studies. So anyway, coming to the study, this is essentially 76 patients were reported. This is patients with T2 and T4A disease who received GemCis plus Nivo into 4 cycles, underwent the DNA sequencing, and then were restaged with cystoscopy, biopsies, urine cytology, and of course imaging, MRI. They were then separated into 2 groups. The CR patients numbered 31, 33 patients did not have a clinical CR. And of the patients that had a CR, the 31 patients, 30 were able to spare their bladder and had no cystectomy and went on to get Nivo for 4 months. 1 patient did undergo a radical cystectomy. And if you look to the curve, the swimmer's plot to the right of your screen, you can see here the outcome of patients with the clinical CR. And you can see here that the red bars represent the patients with no recurrence. Of course, you do have the blue that have the recurrence, but you can see here that we can predict, based on the early assessment, the ability of these patients to preserve their bladder for a fairly long duration of time, of course, when we come to studies such as these. And the CR overall was 48%. Now, there have been newer and more novel approaches that have emerged in recent years. One of them is the TAR-200 delivery platform. This is a delivery device that essentially consists of a silicone kind of a stent. And the stent, when it's put into the bladder of these patients, it curls up to form this device kind of like a pretzel. And many of us in the field have colloquially gone to calling this the pretzel device. But essentially what this is a delivery system that allows you to put an agent in there. And the agent in TAR-200 is gemcitabine. And it's an intravesical drug delivery system. So in this study, the safety and efficacy of TAR-200 was demonstrated or studied in patients as an option when they had muscle-invasive disease but did not want to undergo a radical cystectomy. Patients had the maximal TURBT, they had the device put in the bladder. It releases the chemotherapy at a slow rate over about a week or so. The patients underwent treatment and then underwent a radical cystectomy, and then they were followed up. In this study, the most common side effect was essentially localized. Patients felt they had to go to the bathroom more often. 2 patients did have some urinary incontinence. But really, if you look at the efficacy, in patients with residual tumor after TURBT, 40% of patients with a intravesically delivered gemcitabine had pathologic downstaging, including 1 with a CR. And really, this was something that has spurred on more activity using TAR-200 in the neoadjuvant space. You can see here the phase 1 study of TAR-200 in patients with muscle-invasive bladder cancer who refused curative intent therapy. As I mentioned, the overall response rate was 40% at 3 months and a median overall survival of 20.1 months in these patients. Now, based on this, as I mentioned, there have been an explosion of clinical studies using TAR-200 and satrilimab, which is Janssen's PD-1 checkpoint inhibitor. These trials are called Sunrise studies, and you can see here phase 2b study of TAR-200 plus Satri versus TAR-200 alone versus satrilimab alone. Phase 3 study is Sunrise 2, essentially muscle-invasive bladder cancer patients, TAR-200 plus satrilimab versus concurrent radiation therapy. And Sunrise 4 is a phase 2 study looking at TAR-200 plus satrilimab versus satrilimab alone. So again, we all should always bring it back to our patients, right? So this is a hypothetical name for a patient, Kevin, but a real patient that we see in our clinics, age 64, works full-time, good performance status, and essentially is asking about options to avoid removing his bladder, wants to enroll in a clinical study. And again, we do have clinical studies, so if you have a clinical study open at our center or close by, I strongly recommend that this patient is someone that you discuss enrolling in a clinical study. But otherwise, you can have discussions with these patients on bladder preservation. What's current standard of care, what exists out there, what the future holds. And it's very important for us to also recognize the availability of good, reliable tools. And there are good, reliable tools. There's a lot of stuff out there on the internet that patients go and seek out, and it's up to us to sort of guide them in the right direction. So the BCAN clinical trials dashboard can be used by our patients. And as part of this educational activity, I would beseech you to kind of look for additional information about the Bladder Cancer Advocacy Network. It's a great resource for our patients. It's been around for a long time. Full disclosure, I have helped them from the very inception, and I'm still on multiple boards with them. But it's really by patients, for patients, with guidance from the scientific community. And I encourage you to seek them out. Advise your patients to go and look at their site, but you can also download these resources for yourself, your staff in your clinic, and of course for your patients to hand out. Patients can go here, they can search by geography to find trials that are close to them if you don't have those in your center. So really take a look at the Beacon website. Now let's transition to metastatic urothelial carcinoma. We talked about non-muscle invasive bladder cancer, we talked about muscle invasive bladder cancer, and let's now talk about metastatic urothelial carcinoma. And let's look at the use of checkpoint inhibitors in the metastatic setting and review some of the approaches to manage adverse events that occur in these studies. So before we kind of go on to studies and what's new, we need to know what the current status is of immunotherapy and standard of care in metastatic urothelial carcinoma. So in patients who are newly diagnosed and cisplatin eligible, the standard of care is gemcitabine and cisplatin, or dose-dense MVAC, which we tend to favor in our center. But these both have Category 1 evidence and are Category 1 recommendations. Based on some of the data that I'll show you, in patients that respond to therapy, then maintenance with nivolumab is currently standard of care. In patients who are newly diagnosed and cisplatin ineligible, the standard of care tends to be gemcitabine and carbo, followed again by nivolumab maintenance therapy. And the other options that are available for patients who are platinum ineligible are atezolizumab and pembrolizumab. And in patients that have prior platinum chemotherapy or who relapse within 1 year of perioperative or adjuvant cisplatin-based therapy, pembrolizumab, nivolumab, and nivolumab are options for our patients. So what is the switch maintenance strategy? So we talk about chemotherapy as being the standard of care for our patients, and it clearly is a standard of care, but these patients don't have permanent long-term responses to treatment because after a while, the cumulative toxicity from the chemotherapy catches up with the patient. It's roughly about 6 cycles where the toxicity gets to a point where chemotherapy has to be stopped, and of course, then these patients go on to get recurrent disease. And the thought process in the past used to be wait for recurrent disease and then treat, but that's when the agents were a lot more toxic. Because of the advent of IO agents, which have less toxicity, the thought process for Javelin 100 was why not switch these patients to IO therapy? And the IO here was Nivolumab. So this was Nivolumab plus best supportive care versus best supportive care in patients that had a response to first-line chemotherapy. You can see here that both in the intent to treat and the PD-L1 positive patients, there was a clear benefit to adding Nivolumab to best supportive care. The overall survival and progression-free survival benefits were seen regardless of PD-L1 status, whether the patient had GEM-CIS or GEM-CARBO, regardless of the number of previous cycles, the response to chemotherapy, and the long-term follow-up continues to show benefit of Nivolumab plus best supportive care. The overall survival at 2 years was 49.8% versus 38.4%, and progression-free survival was 23.4% versus 7.1%, with maintenance of long-term safety. So based on this data, Nivolumab was FDA approved for switch maintenance therapy of treatment of patients with locally advanced or metastatic urethral carcinoma who have not progressed to first-line platinum chemotherapy. Now, of course, there are side effects, and the medical oncologists in the audience here and those of you listening online clearly know this, but I'm highlighting this more for our non-medical oncology colleagues who might be thinking about using these agents in their centers. The spectrum of AEs is something that affects any organ. Most urologic surgeons are used to dealing things with GU organs below the waist. This is affecting the lungs, the GI tract, the itises, as we talk about, the skin, endocrine problems, and it really is something that everyone needs to be aware of. It's not just the providing or the prescribing physician, but it's also our nurses, our mid-level providers, our trainees, because oftentimes you'll have the residents or fellows answering these phone calls, and it's very important that they all get trained at an early stage, because clearly IO agents are here to stay and are coming into earlier disease stages, not just metastatic setting. Now, some of the recommended strategies are on this slide here. So if a patient has grade 1 toxicity, continue immunotherapy. There's no reason to stop it right away, but you could consider a temporary delay, and you could consider symptomatic therapy for these patients. If the patient has a grade 2 toxicity, ideally withhold immunotherapy, provide corticosteroids if the symptoms do not resolve in about a week, and prednisone 0.5 to 1 milligram per kilogram per day or equivalent is recommended. The corticosteroids can be then tapered over 1 month to reduce recurrences. And if the toxicity resolves to grade 1 or disappears, then the patient can be redosed with immunotherapy. Of course, if the patient has grade 3 or 4 toxicity, discontinue the immunotherapy, consider hospitalization. Multidisciplinary evaluation of this patient is indicated, and even my medical oncology colleagues will fully enlist the help of their endocrinologists, their internal medicine doctors, etc. So, clearly everybody should do that. High-dose corticosteroids are indicated. Here, the dose of prednisone is 1 to 2 mg per kg per day equivalent. And again, taper these high-dose corticosteroids over more than a month until toxicity resolves, and keep these patients on a taper. Clearly, if there's no improvement or if there's progression of toxicity, we do have to bring in some of the big guns, but this is where you call in a whole team of experts and consider some additional immunosuppressant treatment, such as anti-TNF therapy, and many of the other agents that are listed on your slide. So what are the key takeaways for the use of immunotherapy for a bladder cancer and the implications for a urology clinic? So immune checkpoint blockade with multiple FDA-approved agents across the disease statings has clearly changed the management of our bladder cancer patients. For non-muscle invasive bladder cancer, Keynote 57, which led to the approval of Pembrolizumab, shows strong, durable responses with the agent. It's not in the majority of patients, but it clearly is in about 40% of patients, and it's durable to 16.2 months. In muscle-invasive bladder cancer, we now have the option for patients who undergo radical surgery to be offered Adjuvant Nivolumab based on Checkmate 274, which offers significant disease-free survival benefit irrespective of the PD-L1 status or whether the patients have had cisplatin-based neoadjuvant chemotherapy. And in the metastatic setting, which again may not be for many urologists, but some certainly it is a consideration because you are seeing these patients in your clinic. maintenance therapy with IO, Nivolumab specifically, following platinum-based chemotherapy has now changed the standard of care. It's very important that urologists, who are often the first point of contact for the patients, need to be familiar with the range of adverse events, and these require prompt recognition and management. So now let's transition a little bit to the non-IO approaches for our patients. Although there's a wealth of data for immunotherapy treatment options for bladder cancer, we also have evidence from non-immunotherapy approaches. So what are these? Well, let's review them in the slides to come, and let's talk about FGFR inhibitors first. So FGFR mutations are frequently observed in bladder cancer. Maggie Knowles is one of the experts in FGFR, and this is a review from her, which I beseech all of you to go and look at, which looks at the FGFR3 and the mutations, essentially, in the activating mutations that are seen in bladder cancer. We all know that most of these are found in non-muscle invasive bladder cancer, and they're more often found in the low-grade tumors. As a tumor increases in grade and becomes more high-grade and more invasive, the number of these mutations go down. But they're still present in about 30% of muscle-invasive bladder cancers and about 20% of the patients with metastatic disease. And there has been randomized phase 2 study of anti-FGFR agents. This is with erdafitinib versus intravesical chemotherapy in patients with high-risk non-muscle invasive bladder cancer. This is a study that was reported by Gary Steinberg a couple of years ago. And here patients were screened for FGFR mutations or fusions and underwent either placement into 3 different cohorts. Cohort 1 was high-risk non-muscle invasive bladder cancer, papillary only. Cohort 2 was CIS plus or minus papillary disease. Cohort 3 was the intermediate risk patients that had a marker lesion. And for those of you who are not familiar, what this means is that most of the tumor was resected and one representative tumor sample was kept in the bladder as a marker lesion, and the patient went on to get treatment. And you can see here that in the high-risk non-muscle invasive bladder cancer papillary-only cohort, the patients were randomized to either ERDA or intravesical chemotherapy. In those that had CIS plus or minus papillary disease, these patients underwent ERDA as a single-arm registration arm, similar to the BCG unresponsive patients we talked about before. And in cohort 3, it was an exploratory endpoint with a CR at an early time point at 3 months. Now, if you look at the phase 2 data from BLC 2001, looked at ERDA monotherapy, you can see that there was long-term efficacy in patients with metastatic or unresectable urethral carcinoma. And this long-term efficacy was seen when it came to duration of response, progression-free survival, overall survival, regardless of the FGFR alteration type, the tumor location, the presence of visceral metastases, which again, usually portends a poor prognosis. But regardless of that, these patients derived a benefit. And the objective response rate was 40%. And as many of you might remember, when this was first reported in 2018 and 2019, we were all impressed because 40% ORR with a CR of 4 and a partial response of 36% was very, very impressive. And median duration of response was 6 months. In the NORSE study, where it was phase 2, again with ERDA plus sertrilumab, the preliminary data for this combination has been reported, and this is again in patients with metastatic urethral carcinoma who have FGFR alterations and not eligible for platinum-based therapy. There is, again, you can see with ERDA alone, the objective response rate is 33%, CR6, partial responses of 28%, and in the combination, it's 68% with a CR of 21%, partial response of 47%. Now, clearly, this is really encouraging data, which led to the approval. We have phase 3 THOR study. The question that's answering is, where should FGFR inhibitors be integrated in the treatment regimens of patients with metastatic urethral carcinoma? Where does it really fall? So cohort 1 looks at ERDA versus influline plus docetaxel. And patients have had prior anti-PD-L1 agent as monotherapy or as combination therapy and have had 2 or less prior lines of systemic therapy. Cohort 2 is patients with ERDA versus Pembro and no prior treatment with an anti-PD-L1 agent and only 1 line of prior systemic treatment. So clearly moving this into earlier phases. Now, if you look at the Safety management, again, something that needs to be emphasized is that these agents have a different sort of side effect profile. Hyperphosphatemia is something that is very common with ERDA. Ocular toxicities are common as well, and that's why it's recommended that these patients undergo baseline evaluation with an ophthalmology colleague, something that has to be built into clinics, practices. For example, at a cancer center that is only cancer, you may not have access to ophthalmologists, so it's something that has to be factored in, because if you don't do that, you can really have major side effects that can be debilitating for the patient. Now, genomic testing is something that's important, and it's something that we all should be discussing with our patient because it still is where it's underperformed. So if you look at a recent Flatiron database looking at more than 700 patients who are eligible for Fgfr mutation testing, less than half of them actually had the testing performed. And of those that had testing, 21% had an FGFR mutation, but only 42% actually got ERDA. So it's important for everyone that's taking care of bladder cancer patients to recognize the importance of the discussion of genomic testing with our patients. Another exciting treatment approach for patients with bladder cancer is the use of antibody drug conjugates. So for bladder cancer, there are two FDA-approved antibody drug conjugates, enfortumab vedotin and sacituzumab govitecan. Essentially, what these are antibody, drug, and conjugate. So essentially, you have an antibody with EV, it targets Nectin-4. With sacituzumab govitecan SG, it targets Tropo2. Both of these are targets that are highly expressed on bladder cancer. The linkers essentially link the cytotoxic agent to the antibody. With EV, it's MMAE, which is an anti-tubal therapy. And for SG, the payload is SN38, which is a very, very active metabolite of irinotecan. And in both of these, they're so active that clearly they had to be linked, because otherwise the toxicity level can be extremely high. Now, if you look at the data for EV monotherapy in EV301, these are patients who are randomized either EV or chemotherapy. And you can see here that the ORR was higher with EV versus chemo, significantly higher at 41% versus 18%. And there were no new safety signals that were brought about. So overall survival was higher, the progression-free survival was higher, and the AVs, as I mentioned, are different. They're different classes of drugs. Again, here, the skin reactions, peripheral neuropathy, and hyperglycemia are something that we all need to recognize. They're generally mild or moderate if they're recognized early, but they do need to be recognized. If you look at the other disease states of use of ADCs, and I'm not going to go through all the studies, of course, in the interest of time, but this is EV103 cohort H. The inclusion criteria for these patients are those that are cisplatin ineligible and are undergoing radical cystectomy. These patients are medically fit, of course, for radical cystectomy. They get neoadjuvant EV monotherapy for 3 cycles, and then they have the appropriate management and evaluation of those days 1 and 28 of a 21-day cycle, and undergo radical cystectomy. And the follow-up essentially is every 12 weeks for the first 2 years, and then every 24 weeks thereafter. So in the data that's been reported to date, which was essentially this year at GeoASCO by Dr. Petrolak, the pathologic complete response rate was 36%. Again, a little more than 1/3 of patients actually had a pathologic complete response to single agent EV monotherapy, and the downstaging rate was in 50%. So again, a high level of activity of single agent ADC with EV103. Of course, let's talk about sacituzumab govitecan as well. This is data that was presented by Dr. Tagawa. This is Trophy U01 study, where these patients have multiple cohorts. Here we're talking about patients who receive SG in the platinum and immune checkpoint inhibitor refractory setting. And you can see here that a median follow-up of roughly 9 months, the ORR was 27%. Again, high level of activity with a ADC. Median duration of response, 7.2 months, median progression-free survival of 5.4 months, overall survival of 10.9 months. So really good data. Phase 3, which is a TROPIC study, is underway. This is SG versus physician's choice of either docetaxel, paclitaxel, or vinflunine. Now, again, there are side effects that are specific to SG, the grade 3 or higher treatment-related side effects that we must keep in mind: neutropenia, leukopenia, and of course, you can have anemia and diarrhea as well. So things to really keep in mind with these ADCs if we're going to incorporate them into earlier stages of disease. Because, for example, with EV, there are phase 1 studies now looking at it in the intravesical setting for patients with non-muscle invasive bladder cancer. Now, of course, there are novel anti-HER2 ADCs. This is DXD, as it's called. It's trastuzumab deruxtecan. The linker is connected to the cysteine residue of the antibody, and it's approved, FDA approved for HER2-positive metastatic breast cancer and HER2-positive gastric or GE junction adenocarcinoma. Here, essentially, it has a high drug-antibody ratio, roughly 8:1, with a highly potent payload. And it has been looked at in patients with HER2 high-expressing metastatic urethral carcinoma. It was recently presented by Matt Galsky at GU ASCO this year. And in patients that had the anti-HER2 ADC plus Nivo, the overall response rate was 36.7% with a median duration of 13.1 months. Progression-free survival median was 6.9 months, overall survival 11.1 months. So there's an ongoing phase 2 study called Destiny Pan-Tumor 2, which is looking at this as a monotherapy in HER2-expressing metastatic urethral carcinoma. So what are some of the safety profiles we need to keep in mind? I mentioned them as we were going along, but we need to remember with EV, the neuropathy, the hyperglycemia, we need to monitor the blood glucose, and of course rash, and as an anticipated on-target toxicity. It can be macular, papular, and diffuse. There have been several warnings that have been issued by overseas agencies as well as our agencies here, so it's something we need to keep in mind. But if these are recognized early, these are manageable. The key thing is recognition, and that's why it has to be a discussion between different clinics. Same thing with SG. We need to recognize neutropenia and diarrhea and educate our patients on management with electrolytes, and of course, calling in if they have these side effects and not ignoring them or taking them for granted. So there's expanded treatment opportunities across disease settings with the antibody drug conjugates. As I mentioned, EV-103 and 302. EV plus Pembrolizumab in locally advanced metastatic urethral carcinoma with previously untreated advanced urethral carcinoma. EV-303 is perioperative Pembrolizumab plus enfortumab vedotin and cystectomy versus cystectomy alone in patients with cisplatin ineligible muscle-invasive bladder cancer. SURE-01 and SURE-2 is neoadjuvant SG plus or minus Pembrolizumab before radical cystectomy in patients with muscle-invasive bladder cancer who can't receive cisplatin-based chemotherapy. EP plus Nivo plus SG is also being looked at, and of course Ddr plus Vicinium for high-grade non-muscle-invasive bladder cancer is a treatment paradigm that's incorporating ADCs with IO in this group of patients. So the key takeaway for you is that multiple classes of agents have shown efficacy across early and late-stage disease, even outside the IO regimen. There's ADCs, there's FGFR inhibitors. Each therapy is, of course, associated with unique indications and modes of administration and AE profiles. And it's important to keep in mind that we need to reconnect with our patients in a multidisciplinary care fashion. It's even more important today that the urologist, the surgeon, the medical oncologist, the radiation therapist, our support staff, our pharmacists, everyone comes together and provides our patient with the best shared decision-making opportunity to allow the patients to engage and find the right treatment for them. And I want to again give a shout out and urge everyone here to reach out and use the Beacon website. It's an excellent resource for professionals, patients, and their caregivers. It's not just us and our patients, but also their caregivers that get a lot of information from this website and provides a lot of educational resources to help patients feel more prepared along their journey of bladder cancer, whether it's early stage, invasive, or even metastatic. So thank you for joining us today. In summary, we've seen the evidence that supports different approaches for treating bladder cancer across multiple different disease settings, representing positive alternatives for our patients. Of course, each approach comes with considerations that must be weighed in by the urologist, the medical oncologist, and other clinical team members, as well as the patient. All team members should be prepared to have this discussion about treatment choices with the patient so we can identify what best fits the needs of the individual and utilize a shared decision-making approach. I'd like to remind you to download the practice aids associated with this educational activity as a resource for you, your staff, and your patients, of course. Thank you once again, and we hope that you found this educational activity informative and useful for your practice. Thank you very much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RMY860. This activity is supported through independent educational grants from AstraZeneca, Bristol Myers Squibb, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC.